invite Ritesh to talk on artifacts and interpreting OCTA in presence of artifacts. In the interest of time, we'll take questions at the end of the session because we're a little backed up. Thank you.
Good afternoon, and thank you, Dr. Avnendra Gupta, for inviting me to this introduction course, and Dr. Anand for introducing me. I'll be talking about interpreting OCTA findings in setting of artifacts. As I talked about in my introduction, OCTA is a very beautiful tool, and we are learning so much new as we are dealing more and more with OCTA. It provides us with a non-invasive high-resolution imaging, which are very nicely depth resolved into different segments, as Dr. Avnendra had pointed out. But no other retinal imaging modality has so much discussion on interpretation and features of interpretation as OCTA has. And the major reason is OCTA and artifacts somehow go kind of hand in hand. Even the word artifacts has two connotations, I've just put it there. Both are right. So OCTA and artifacts practically go hand in hand. And I would put a disclaimer very openly. All OCTA angiographies are subject to artifact risk. And please read them with very carefully understanding this artifact and reporting them accordingly. So artifacts can arise in OCTA, which can be because of patient-related factors. This can be because of some image device or the algorithm limitations which are there, which can all lead to artifacts. Also, there are a lot of patient factors, means what patient cooperation factors and also patient disease-related factors. I'll be talking about them as we go in the slides. When we are interpreting OCTA in presence of artifacts, it's very important we take certain steps to mitigate their influence. We also, which I'll again discuss in detail, we also look at the clinical context of the disease. We look at other imaging modalities to corroborate our images. And at the end of the day, use a wise clinical judgment to finally come up with an answer. If we know our machine and a disease and the OCT angiography machine and the disease well, we'll be able to understand the limitations and the source of artifacts, which can help us improve the accuracy and reliability of our OCT interpretation. So coming to artifacts, there are multiple list of artifacts. I'll be touching upon some common ones. I'll start off with some of the artifacts which practically happen because the image acquisition was not appropriate or patient was not cooperative. You can have blink artifact where a segment of OCT angiography images are practically missing in the center, or you can have a band artifact where a patient moved during the scan being taken. In these conditions, one has to repeat the OCT angiography. This is checked at the level of the operator. A better cooperation from the patient can be taken at this stage and repeat the OCT angiography at this stage itself. Again, because of acquisition problems, you can have stretch artifacts and duplication artifacts wherein you actually see the same vessels twice in the same patient. Even dry surface, when the cornea becomes too dry, you can have this kind of artifacts coming up. If there is a fixation issue, consider taking a smaller size scan. We have been talking about how OCTA has expanded to 12 by 12 montage and 12 by 12 6 by 6. But remember, the larger the area that you're going to be scanning, more the time the patient will have to sit in front of the machine, more will be the number of A scans being taken, and the lesser would be the cooperation coming from the patient. So if you have a lot of artifacts coming in, it's better to reduce the size of your scans so you can have faster scans. Again, machine differences would be coming into play, but a smaller scan generally would have lesser number of A scans, and then you will be able to have maybe a better quality image, which are because of patient factors. As I said, if you know your machine, Dr. Gupta talked about it, how different machines have different kind of scans, which have been shown in this slide, how an RTView from Spectralis varies in the number of scan speeds that they have, and the scan speed will determine how much time for acquisition it would be taken by each of these machines, also by the slab that these machines are taking. Also, you can have artifacts because of certain attenuation factors coming from something in front of the retina. So maybe a blood clot or a big floater, it will have something called as flow signal attenuation artifact or shadowing artifacts. The light is blocked when the image is being acquired, which does not permit the light to reach deeper levels. Suppose you have a really thick hemorrhage sitting right in front of the retina, you may not be able to acquire these images. Decentration artifact also happen because of the time of acquisition, and again requires one to repeat the scan at the same time. Two very important artifacts which we deal with daily are projection and segmentation artifact. I'll first talk about projection artifact. Basically, artifact means when the superficial blood vessels get reflected into your deeper scans also. This leads to very false positive kind of signals coming from deeper layers, creating host vessels and us to interpret these signals as probably we are dealing with the neovascular membrane. This is typically more important when we are dealing with wet ARMD cases where you are looking at ORCC slab or choriocapillary slab and you're trying to look for vasculature there. So projection artifact can disturb us there. They also get disturbed more when the contours of the retina are disturbed with presence of pigment epithelial detachment, which causes the retinal surface to contour in a different way, and these projection artifacts come. I'll share with you an example here. Important thing what Dr. Gupta also mentioned to rule out or look for projection artifact is to switch on your B-scan flow signal. So that's one of the easiest way to look for projection artifact. When you switch on the flow, this is corresponding images with flow off and flow on. When you switch on flow on, you start seeing these vessels appearing as, do I have a pointer here? Cursor is not, cursor, okay, okay, yeah. So when you switch on the flow here, you can see these red flow signals coming up in the superficial layers. So what is recommended is you look at the flow from the superficial, then you look at the same flow in the deep layer. If the flows are really corresponding with each other, there is more likely to be an artifact from projection, a projection vessel which is getting reflected onto a deeper layer at the level of RPC. While if you look at this particular flow here, this is coming from actually the diseased vessel here, which is coming only from the network here. There is nothing corresponding on top of it. So this is an important, easy way to determine whether you're looking at projection artifact or not. Again, just to highlight the same thing in a more expanded way. These are all signals coming from your main vessels in the superficial plexus, while this is your actual diseased vessel. So, when you're looking at projection artifacts, you look at corresponding NFLAS, slab analysis, you carefully look at layer by layer. Dr. Gupta talked about scanning the OCTA angiography from top layer to bottom layer. You can actually see the vessel being reflected into the same vessel anatomy being seen in the deeper layer. You switch on the flow and then also look at your other imaging modality to confirm whether this vessel is actually there or a projection artifact. Next is segmentation artifact. Segmentation artifacts typically happen when your segmentations are not correct and one vessel from an upper layer gets reflected in your segment in a deeper layer or so on and so forth. Why I put this slide up is because to make you understand that segmentations in different machines vary. Each of these machines have different algorithm. So if you look at the comparison of angioplex versus spectralis versus angioscan, the level at which they are calling superficial may be different from what another machine is calling superficial, and what they are calling ORCC start is not the same as another machine. So when you're moving patients from one machine to another, or when you're interpreting patients with scans coming from different machines, just keep this in mind that the slabs may not exactly be accurate. This happens sometime when people try and interpret whether the network is shrinking or not. But if your machines are different, you may get falsely wrong impression that the slabs are actually, the networks are shrinking or not. So keep that in mind and try and as far as possible repeat your OCTA angiographies with the same machine, same protocols. Another example where to show how an segmentation artifact can trouble you. This is a 6x6 angiography scan from the Cirrus 6000. So if you look at the segmentation which has gone from here, this looks like a network which is sitting at the level of the deep plexus here. You go further down, I have segmented this area. There's a big network here. But the NFAS made me suspect, no, there is something different here which is separate from the rest of the disease area. So on NFAS, I could see some entity in the superficial part. I took my segmentation correct. I went to the RP fit scan, took my scan cross here to that level, and that is exactly what I get a complete network on. So the way you segment your disease will give you the correct interpretation of the disease. So you point your crosshair at the right place, you select the correct slab, and then you will be able to pick up the complete network. Another patient, multiple drusen's with segmentation happening at the superficial level, wondering where actually are you dealing with, where is the network? Is this the network? Is this the network? I have a RP fit slab. Is this a vessel or not? So just moved the slab a bit, adjusted it according to my requirement, and this is actually the complete network which I can get. As Dr. Gupta pointed out, you sometimes need to go back, sit on the machine, spend time, move. You can change these segmentations also. You can move your segmentation thickness. You can, these are prefits, but these prefits can be adjusted to look at the disease in more detail. So this is the complete network which we were talking about. Similarly, in the other eye, where actually this polyp is there, which is visible as a high flow signal under a PED and a network here. Last word of caution, too much of manual segmentation can also introduce artifacts. You may be over-diagnosing things also, so just be careful. Don't start too much of it also. To summarize, OCT angiography as a tool has added a lot to our armamentarium. It requires it gives us a lot of in-depth analysis about the NFAS visualization of the disease. But artifacts are its weakness, and with careful understanding of these artifacts and how to overcome them, we can really come up with much better diagnosis. Only thing I would say, spend time with your machine and your picking up of artifacts would become much better. Thank you.
Actually, thank you Ritesh for very informative talk and very good illustrations. I'll request Puneet to come and have. One thing what I will suggest, you can also increase the width of the slab. You can increase the distance between the two slab and you can get more information, like what you see in ORCC. The slab is wider. If you think the slabs, you can go on to RP fit and increase the width, you can get more kind of information. Any questions from the audience about these two talks? We'll take up questions from the audience. Yes?
The last 10 years or so, even if I send my patient down for an OCTA, I have to give specific instructions to the operator to what slab he's supposed to take or what exact area he has to focus on. Do you have any suggestions on how to overcome these difficulties maybe in the future?
So to answer the first part of your question, yes, it is very much dependent on the person who is taking the scans and sending it to you if you are sending it outside. Generally, at a big practice like where I am working, where we have so many OCT angiographies happening, we generally follow a standardized way of scanning which have been explained to the operators who are doing it. If we need anything specific done, we have to put a remark on at the time of sending the patient up. Generally, what we recommend for all our patients is to take a 6x6 slab, which is generally a recommended 6x6 at whatever machine it is. If it is Heidelberg, it is generally 20 degree by 20 degree. And if we need a white field, we'll specifically ask for it. Or if there is specific area we need to localize, you have to ask for it. And yes, you rightly said, it's not as clean as an OCT, where you just send and it comes back to you. You are dependent a bit upon the person who is doing it.
What I do in my practice is I ask my technician to take the slabs acquisition, and then I go on the machine and do a segmentation and print out by my own. So this way, the only thing is we have, I can go in next room and take the slab and give the report. Other thing what you can do, if you are using Zeiss system, then you can get in information or the Zeiss flow where you can do all this manipulation in your room. So that is very helpful. But yes, interpreting OCTA, you need to sit on machine, and by doing a lot of segmentation and watching, correlating a lot of things together, you come to learn a lot new things over a period of time.
I just wanted to ask Dr. Aminder that in SD-OCT, how there is more better resolution, though the wavelength of swept source is more, 10
That's what I mentioned. The resolution is less in SD-OCT. In spectral domain, it's more as compared to an swept source is OCT.
Because more wavelength has better penetration. How come that?
Penetration is more, you will get a better choroidal images and better scleral images, but the retinal images will not be so clear.
The resolution of the superficial plexuses are much better, or the retinal vasculature is much better with spectral domain OCT, but the choroidal networks are picked up much better with swept source. So that is the difference seen.
Yeah, good afternoon, everybody. Yeah,